Well, good morning. Welcome to a lecture on the heart. So we have talked about hypertension, atherosclerosis, and those things they're going to feed right back into heart issues. And we can look at cancers of the heart are pretty rare, but infection of the heart, very, very possible. We'll talk about endocarditis, the inside of the heart getting infected, or myocarditis, the muscle of the heart getting infected. Valves can have issues. Often you look at the heart, the people that fix it are electricians or plumbers. So you're looking at, is there issues with the electrical system, or is there an issue with the valves and the pressure being formed? So we'll cover really everything here. That's one of your major killers, heart disease. All right. So yeah, we're going to start the review very rapidly because you guys have had this in E&P. I'm sure you know all your heart chambers and your valves, everything like that. So I'll just throw a couple slides on here just to get us in the mood. Well, it's located in your chest, this heart. Normally goes to the left like that. There's rare cases where it goes to the right, called dextrocardia, but very rare. You can see it'll be found, and you see when you guys studied where to put ECG leads or where to listen to the heart. You know, like be down to like about the fifth intercostal space there. It's about as far down as get to the apex of the heart. And it sits on the diaphragm, and the diaphragm is moving. Your pleural cavities next to it are moving. The heart is beating inside this pericardial sac, and so it's a very dynamic region there. A lot. If you ever watched a open heart surgery on YouTube or something, you know, that thing is beating and jumping around in there and everything is moving. So pretty cool. So our heart, of course, is a four-chambered heart, and we have two sides. The right side is going to receive the blood from your body, right? Your superior vena cava from your head and your arms, inferior vena cava, your legs and the rest of your body, all feeds into this right side, to the right atrium. And then the right ventricle is going to pump out the pulmonary trunk to the lungs to get oxygenated. Comes back from the lungs into the left side. So your left heart, which is actually much bigger, the ventricle is much stronger and bigger because it's got to pump that blood under a lot of pressure out your aorta to your body. The right side is pumping to your lungs, which are at the same level, and there's a lot less resistance. So the left side of your heart generates a lot more pressure. And we'll see when we talk about heart valve defects, it's almost always the aortic or the mitral on the left side compared to the right. And your valves again, 4 of them. The big ones in the right and the left between the atria and the ventricles, valves keep blood moving in one direction. And we'll see how they can become narrowed and solid, called stenosis, or they can become incompetent. They're not working. They prolapse, they flip up, and they're not working as they should. So both of those will cause problems. And just for the anatomy of it, on the right side is the right atrioventricular valve, commonly called the tricuspid valve. The left one has 3 names, really. You call it the left atrioventricular valve, the bicuspid, or it's often called the mitral valve. And a mitre is a pope or a bishop's hat that kind of has a look like the valve. That's why it gets that name. And this view really shows it. On the left, you can see it's a little hard to tell. The cusps of the valve are not as obvious as the beautiful valves you find in the aorta and the pulmonary trunk. These are the semilunar valves, or the half moon valves, and they have normally 3 cusps. You can see them here: pulmonary and then aortic behind it. Yeah, so those valves are always working to keep blood moving one direction. You don't want to regurgitate and go back the way it came. There we go. Guys, take a look at it. Don't forget the wall between the chambers is this to be the interventricular septum. And then the interatrial septum will be between the right and left atria. So you can have septal defects, problems in that wall. We see the valves, we see where the blood is going, where it's coming from. right? So the right side receives the blood, sends it to the lungs. It comes back to the left side, and that pumps it out to the body. All right, we got it. Physiologically, as learned in blood pressure, 120/80 is your systolic over diastolic pressure. So systole is when the heart, the ventricle is contracting and pushing the blood out. And diastole is the relaxation, the pause, where it's opening up. It makes a suction even, and that's going to fill the chambers, the ventricles, in preparation to push it out again. So systole, diastole will continue as long as you're alive. So valves can have issues. We'll talk about how you can have bacteria growing on them. They become damaged. They can become calcified. They're very delicate, thin flaps covered by endocardium. And so they need to be working correctly or you can have issues. An incompetent valve is incompetent. It doesn't do its job. And it's going to allow blood to regurgitate or go past the valve. The valve should snap shut and stop blood from going back. But an incompetent valve doesn't. Stenosis means a narrowing. And in that case, the valve often becomes more solid and not as flexible. And so you can imagine if you have an aortic valve that becomes stenotic or less flexible and narrow, your heart's going to have to pump harder to push the blood out of it because it's not as flexible anymore. And if you listen to this, you can hear that murmur. As you can imagine with a stenosis, we can look at. Normally you hear lub-dub, lub-dub. And those are the sounds of the bicuspid and tricuspid shutting. It's the first sound, lub, and then the aortic and pulmonary valve shutting, dub, lub-dub, lub-dub. And if the aorta aortic valve doesn't allow blood through easily, you can see how that's just like you're just pushing the blood. So often that left side will become hypertrophy. The muscle gets bigger because it takes more pressure to open that valve to push the blood out. You can often hear opening and then shh as it travels through the valve. Instead of going through quickly, it takes a longer time. So you can see how the sound is just pushed on like that. And we don't need to go into all these heart murmurs. Yeah, I'm not going to ask you about them, but when you do learn about these, it's going to make sense if you understand what's going on. If the valve is narrow, it takes longer for that blood. It's going to be noisy as it gets pushed through there. Yeah. And this shows nicely over here. You can see this is normal right here. You can see beautiful. The valve opens up as the blood is ejected out of the ventricle and then shuts completely with no regurgitation. That's a beautiful valve working perfectly. But here, look at this side. You can see, it's got little holes, a little bit leaky there, and especially it can't open up all the way. So it takes more pressure to push the blood through that half-open valve like that. And so if you have an aortic stenosis, aortic valve stenosis, the blood is being prevented from shooting up the aorta. And so your ventricle muscle has to work harder. So you're going to have hypertrophy or growth of that left ventricle muscle wall get bigger. You get an enlarged heart because of that. And if it's a problem with the bicuspid or mitral valve, that means that right ventricle, it gets rid of the blood down into the as I say, right, left ventricle, left atria. The left atria is going to push the blood into the left ventricle, and it's going to get bigger. But the left ventricle goes, and blood goes back into the left atria. It shoots back, and so that's going to become a dilated, and that muscle is going to get stronger to try to get rid of that blood because the left ventricle keeps kicking it back up because the valve doesn't shut properly. So you can see with a mitral valve problem, you're going to have an atrial hypertrophy. And if the heart can't get rid of the blood out of the ventricle is going to get bigger. So your heart itself needs lots of blood. You can imagine this is muscles that are constantly contracting. So lots of mitochondria, you got to make a lot of ATP, they need a lot of oxygen, a lot of blood, a lot of glucose. And so it's fed, you guys remember, by the coronary arteries. The main branches are left and right coronary artery that comes off right after the aortic valve. And then that splits into many, you probably learned a few branches that are going to go through the whole heart muscle. And then veins will drain the heart back into the right atrium through that coronary sinus. All right. So these coronary arteries, all these branches as they branch through the muscle, this is where issues are going to come about. When you have atherosclerosis in these arteries, it's going to shut off blood supply to your heart muscle, which desperately needs lots and lots of blood, right? And then the electricity of it, just review, you guys know, the SA node's really in charge. It sits up there, and it's always got the brakes on it. Remember, from the vagus nerve, kind of parasympathetically saying slow down a little bit, but then it's sending the signal, and adrenaline or sympathetic nerves can speed it up. Parasympathetic nerve will work kind of as brakes, and it's sending the rate. And as you exercise, it speeds up. As you're resting, it slows down. When you have a fever, it speeds up, and many other causes. But the SA node is going to send the signal out. And because there is a connective tissue here in that skeleton of the heart, it's the atria are separated electrically from the ventricles. And the AV node right here is going to, there's a little delay between the atria contracting. And then the little fibers are small so that the nerve impulse slows down. When the AV node shoots, it goes down the septum, and from the bottom up, the heart is stimulated. So the ventricles kind of ring up and they empty upward. Yeah, and things can go wrong with electricity, like the electrical system as well. Be arrhythmias when you have that's a heartbeat that's not the proper rhythm. So most frequent and serious problems, let's just run through them here. Atherosclerosis, again, the hardening of the arteries is going to be the precursor to a lot of problems. Most commonly, atherosclerosis is going to be a narrowing of an artery. There's going to be usually a clot that's going to jam in there and close off the artery completely. And then you're going to have a myocardial infarct. You're going to have a death of the tissue downstream from that constriction. And MIs are most common, and you think about men getting more heart attacks than women, and that's true up to age 65, and then in the elderly, it evens out. But women can get heart attacks too, just you hear it's more common in men, younger men. Yeah, so MI, and this shows beautifully, they can do, this is an angiogram. When they put in some contrast, take a picture, and they can see here this narrowing, and they can diagnose the problem. Yeah, arrhythmias, we're going to see the most dangerous is a VFib, ventricular fibrillation, and then there's other ones. Angina pectoris is when you have chest pains. It's kind of a precursor to a full-blown MI or heart attack. It gets better when you rest. And congestive heart failure, when you hear that, that means that the heart has inability to pump out the blood that comes to it. And so it can't do its job. And so you're going to have a backup of pressure behind it. And hypertension, I talked about how it's so important, and it needs to be, you need to keep on top of your blood pressure because we can control it. We can stop a lot of problems early if you diagnose this. But when you have too high blood pressure, your heart's got to work harder to get that blood out of there. And it's ultimately the cause of high blood pressure because it's causing the pressure. But if your vessels are all hardened, you're not going to have the flexibility, and it's going to cause hypertension. But you can take a look and see as your heart works harder and harder to push that blood out, it's going to hypertrophy, and your heart muscle is going to get bigger. And you say, oh, that's good. And in some cases, a bigger heart is better. And an athlete, big heart can pump out more blood. But as it gets pathologically, as your heart enlarges, it turns out it becomes less flexible and harder to get rid of that blood. So left ventricular hypertrophy, yeah, you mentioned earlier that can happen with a stenotic aortic valve, so it can't push the blood out. But if your blood pressure, systemic blood pressure is high, that heart's got to work harder because it has to make the pressure higher than it is in the arteries to push the blood out. So left ventricular hypertrophy, hypertension will cause that. On the right side, what about right ventricular hypertrophy? Well, in that case, the right side is pumping out the pulmonary trunk to the lungs, right? So if the lungs, the arteries become blocked, it could be an embolus, it could be the scarring or COPD in the whole lung. It has a problem with the blood getting through it. The right side's got to work harder to get that blood out the pulmonary trunk, the pulmonary arteries to the lungs. So right ventricular hypertrophy is when you're going to have pulmonary hypertension or high pressure in your lungs, more resistance in your lungs. It takes more pressure to push the blood through it. Congenital heart disease, we talked about this with developmental issues. And yeah, if you have persistent holes in your heart or congenital valve problem, whatever it is, that usually is going to cause problems in childhood early on. If you're going to die of a congenital heart disease, it's usually in the first year. If you can make it past that, and some things you're going to see, they come up later in life, they build up. Rheumatic heart disease, we'll talk about that a little bit, but what it is it's often the strep bacteria in your throat. They cause your body to make an immune response and to make antibodies against it. It turns out that bacteria in your inner lining of your heart must be similar enough that these antibodies will attack the heart lining, especially the valves. And so we'll see rheumatic fever, rheumatic heart disease can damage your heart valves. Yep. And then, of course, when you have problems in your lungs, COPD, chronic obstructive pulmonary disease, things like that, it's going to cause backup and more pressure for the blood vessels going through your lungs. Yeah, so sudden cardiac death. If your heart stops pumping, you die very quickly, right? Yes. And usually this is a cause of atherosclerosis and myocardial infarct, fibrillation kind of thing. And I'll show you a picture, particularly of what VFib looks like. And it's going to be an issue if your ventricles can't, pump, pump, pump. That's what you want them to do, not that's not good. Cardiomyopathy, we'll talk about that. This is a disease where your heart muscle, it's a genetic disease where your heart muscle just enlarges, especially the wall in the left ventricle, and it's a big cause of people that previously healthy athletes will just drop dead, and they had this genetic disease, and we'll talk more about it. Yeah. And stenosis, particularly the most common one is in your aortic valve, and one of the major problems. All right. So what are some of the symptoms? Heart attack. And you all know, you all know this. You guys in particular are well educated, but most people know the signs of a heart attack. And many times before you get a full-blown MI, you'll get angina. Angina pectoris is chest pain during exertion. And so, all of a sudden you decide, I'm going to run this 5K, and you haven't, trained at all. Not a good idea, right? Or you see it a lot when the first snow comes and guys out there that are out of shape start shoveling the driveway, and you really are testing your heart then. But the deal with angina is that once you rest, you feel better, or you take some vasodilators and those arteries get bigger. But you should get it checked out, because it means your heart, when it's strained, you have an occlusion of the vessels, but it's not completely off, so you don't have a heart attack yet, but it's telling you that during exertion, part of your heart muscle is gasping for air. And that's a good time to go in, get an angiogram, and they can take a look. Oh yeah. And then they can preemptively, open those arteries before you wait until it's an actual full-blown MI. But the signs, of course, you feel like and they can vary, and sometimes it's asymptomatic. Doesn't that sound crazy? Some people have heart attacks, they don't know it. You should probably say, well, how do we know? Well, you go, maybe you have a second one, or they can go and you can see you have blood levels of some enzymes are up, and they can look at your ECG and like, you had a heart attack. So believe it or not, many times it's asymptomatic or atypical. And many cases, women have a lot of the atypical signs where it's not necessarily chest pain, maybe a back pain, other pain, or you feel nausea, or you just don't feel right. Shortness of breath, not without the chest pain. So these things can happen. These doesn't have to be, but the typical symptoms that a patient will feel would be this tightness in the chest. People describe it as like standing on my chest. And the pain often radiates down your left arm or up your left jaw. It's called referred pain. You guys remember that from A&P. So that's the typical, and you'll have shortness of breath and anxiety, things like that. But normally you feel this chest pain, and then should immediately go to the doctor if it's obviously not going to go away. Congestive heart failure means that your heart is not able to pump out the blood that goes to it. And then absolutely what happens is that you have buildup of back pressure. It's like if you have a really slow cashier, the line is going to build up behind. Same thing. If you're not getting rid of the blood, pressure is going to build up behind. And normally, imagine on the right side, if you're not getting rid of the blood, it's going to, well, right side, let me start over again. Let's say your heart's not getting enough blood. Your left side is not pumping out to your body. It's going to back up in your lungs. And higher pressure in your lungs is going to cause pulmonary edema. Fluid is going to come out. More fluid is going to come out than should in your lungs. And other edema, peripherally, especially the ankles will really swell up. Ascites is you have fluid coming out in your abdomen. You'll see neck vessels bulging. So you'll have a lot of edema because pressure has built up because your darn heart can't get rid of the blood. And yeah, it shows how you can, through physical exams, you can see this. You see the fullness of the neck veins. You can press on the ankles and you'll see that pinpoint edema where the fingerprint stays, it doesn't come back. That means that you've got excess fluid in your limbs. You can usually just see that. And you can listen, auscultation or percussion on the chest. When you percuss the chest, fluid-filled lungs sound duller than if it's air. And you can obviously listen, and during breathing, you'll hear that. If there's fluid in the lungs, you feel a crackling or kind of a mixing of the fluid in air. And a good cardiac physical exam, you want to take blood pressure. You want to feel the pulse. And you'll see from a later disease, you could feel the pulse both at the wrist or neck and in the lower limbs. Talk about disease where that would be actually different. And listening. Of course, auscultation. You can listen various places. Remember to hear the different valves. There's different places to listen to that. And look for an enlarged heart. They can do things to estimate heart size. You can do a radiograph. I guess that's serious, but blood pressure, pulse, and then listening are real easy things you can do. And then maybe take an ECG. Maybe you'll see further tests like echocardiogram or you can catheterize it. Do a lot of things if you're really looking in there, but you can tell a lot of things just from listening to the heart and checking the pulse, etc. Oh, and here's some of the fancier things. These are things that would, if you definitely have a heart issue, you want to look a little closer. So you can do a chest X-ray, and we can take a look at the outline of the heart and see if it's enlarged. Echocardiogram is a really cool tool. Look at this animation here. It's fantastic. So we use the ultrasound like we do to look at pregnancy. And we get a beautiful view. You can see the valves working, the blood. Yeah. Oh, so cool. You can do an echo on the chest, or even a better one, but it's more invasive, more dangerous, is to do a transesophageal, where they'll put the machine on the other side of the heart. So the chest from the back side, be able to do that. It's much more involved. Of course, an ECG, you can hook you up. A&P lab hooked you up. 5 minutes, we can hook you up and see your ECG up there. And that'll tell you a lot. You can see there's different kinds of, you guys probably get into this, STEMI, you get an elevated ST interval and things. There's definitely clues that will tell you what's going on in your heart if there's electrical impacts. And then, we take a blood sample and we look for these enzymes, troponin and the CK. When you have heart muscle damage, it gives off enzymes that we can detect, and it tells us a lot. If you can do a cardiac catheterization, I mean, then you're going to insert a catheter, a needle, in through a blood vessel, the neck or the groin, and bring it up right into the heart. And you can inject some dye and do an angiogram. We can see, oh, what's going on in the blood vessels in your heart. You can see it real time. So it's a beautiful thing. But yeah, but this echocardiogram used a lot, and you can visualize the valves and see if there's a vegetation or if there's an issue there. It's beautiful. All right, so if you have a congenital issue or genetic issue with your heart, usually that shows up early, and you can see they do surgery even on infants, even prenatally. They can do some cardiac surgery, which blows my mind. If they can detect it early, they can often do surgical interventions and fix it. And some things, they don't show up until later, like I said. But the common kind of genetic issues, the most common is this: your aortic valve is supposed to have 3 cusps, but a bicuspid valve comes about commonly, and it's not ideal. And what usually happens is later in life, it becomes stenotic, or it becomes damaged. It's just, so often maybe you're older, you're like, oh, did you know you had a bicuspid aortic valve? And you didn't know. You've lived your life, you went through sports and everything like that, and so all of a sudden it's going to start break down. And so you can see here it has 1 cusp, and these 2 are fused right here. Yeah. And so if this aortic valve becomes more solid and harder to open, when you listen, you'll hear that murmur, and sometimes you'll hear like a click as the pressure builds in the left ventricle. All of a sudden it's strong enough to push it open, and it kind of opens all of a sudden. It makes that click, and then usually the sound drags on for a while instead of just like a quick sound. So that's a good sign. And then if you do an echo, and you'll be able to say, oh, look, they got aortic valve problem. Yep. And so you'll have congestive heart failure if you cannot pump out enough blood. This valve, yeah. So it's a congenital issue. You're born with just 2 cuffs on it, but over time, the valve becomes incompetent and stenotic and not working, and then needs to be fixed. They can go in, they can give you an artificial valve, they can do some things. Now, septal defects, about 30% of these congenital issues are septal defects, problems in the wall. And you have a normal hole in your interatrial septum, don't you? And I know you all studied this, that foramen ovale. When you were born, when you're in utero, your lungs aren't getting oxygen. So you get oxygen from mom's blood through the umbilical cord. And so there's 2 shunts or bypasses of the lungs. One is this hole in the atria. So that blood returning from mom's umbilical cord doesn't go to the right side out to the lungs. It goes right over to the left. It's filled with oxygen anyway. It doesn't have to go to the lungs. And the other one is this little duct right here. There's a little duct between the aorta and the pulmonary trunk. It's called the ductus arteriosus. And then as an adult, it's the ligamentum arteriosus, or arterial ligament. It's just a ligament in adults. But it was a big duct. Another bypass that's going to, hey, we're not going to the lungs, we're going out to the aorta. So these 2 things, as you're born, they close off. But a persistent foramen ovale, PFO in the business, this hole can be just the size of a pencil lead, or it can be huge. And if it's you may not have you may notice a slight murmur, and you may live with a patent foramen ovale and live just fine if it's small enough. You may notice it upon exertion, or you may not notice it, like I said. But a big one needs to be fixed, because you got mixing of blood. You're not going to be able to keep enough oxygen if there's a big leak like that. And an even worse one would be a hole in the interventricular septum, that one, because there's a lot more pressure on the ventricles. And so a lot more pressure on the left side. So what happens is that when the ventricles contract together, that blood on the left just shoots over to the right. And the right side's going to dilate, and it's going to be some issues. And blood it's not going to be going where it's supposed to go. So an interventricular septal defect, more serious and interatrial, and both of them are going to allow mixing of blood. There should be those walls should separate them. And I already talked about the Tetralogy of Fallot, I don't actually know, but that is going to be something where there's these 4 changes, and this is the most common cause of a cyanotic baby coming out blue because it's not getting oxygenated. But here you've got a big hole in the ventricle. And the pulmonary trunk is small, so not much blood's getting to the lungs. And the aorta is big, and it gets blood from both sides, and so including the non-oxygenated blood. So you're getting this mixture of fresh blood and old blood, and it's going to cause you to be bluish. All right, here. And I bring this up because that's why I talked a minute ago about the remnants of fetal circulation. That foramen ovale can stay open. It's supposed to turn into a fossa ovale. It's just a depression. But if it's open, it's a foramen. A foramen means hole, right? The other one was that duct. And that duct here is supposed to close off completely. And it can remain patent or open. But what I'm talking about here is at this point right here, if you look at most aortas and cadavers, there's a little dimple right there. A little dimple, maybe it's just very subtle. But hey, that used to be a duct in there, but it's healed over, right? That's a good place where you can have a constriction. So coarctation of the aorta is the aorta is constricted right there. And what happens is that you're going to have high blood pressure before it, but then beyond it, you're going to have low blood pressure. So it's causing a backup. This narrowing is causing the pressure it takes more pressure so you have hypertrophy of the heart if this continues, and lower pressure in most of your body, but higher up here in your arms and legs. So really the fascinating thing is if you feel the pulse in the neck or the arm and the leg, it's high of hypertension here, but it's low in the lower limbs. Do you see why? Because the blood is going to leave to go to the arms and the neck, and that's where the pressure was, but because of this constriction, the pressure is low for the rest of your body. So this cool kind of mixture there of blood pressures. Yeah. And hopefully they can figure this out pretty quickly. And then if they find it early, you can go in there and put a stent in there to keep it open. See, no problem if they can fix it. All right, this hypertrophic cardiomyopathy. So cardio is heart muscle disease. And this is a genetic disease where it can be mutations that are going to cause your heart muscle to not form correctly. What happens is the heart muscle thickens. It gets thicker, especially in the wall, the interventricular septum. And as this thickens, it's going to be harder for the ventricle to fill up, and it tends to impede the aortic exit, and so it's harder to push blood out of the heart. And so your heart muscle gets bulkier and bulkier. And as your heart this hypertrophy, one of the things that happens is that it's harder to perfuse. So the coronary arteries can't handle getting enough oxygen to that much more heart muscle. And so you have ischemia of the heart muscle. Arrhythmias can form. And like I say, it's some high profile athletes, up and coming, usually college athletes, will just fall dead on the basketball court or the football field. Because they had this hypertrophic cardiomyopathy. So there's some, you can Google it, look and see how, should athletes compete if they have this, what kind of screening should be done. But it's a genetic disease of the muscle, hypertrophies, and can cause sudden death. All right, well, you get older, degenerative diseases come about. We'll see cancer is unlikely in the heart, but atherosclerosis really does happen quite a bit there. And you can have inflamed heart because of disease as well. Yeah. So this is a critical organ and many causes, but similar outcomes we're going to see is going to be, you're going to have a heart failure. So we talked about these atherosclerosis plaques. The inside of the vessel, you're going to have, starting with just a fatty streak, you're going to have fats and macrophages infiltrating your endothelium, and then the plaque builds with cholesterol. It can calcify. There's blood, and these plaques, they can be stable or they can then they can all of a sudden break and cause clots to form, or it can bleed and push the plaque out. And so these plaques, they grow slowly in your coronary arteries, but there comes a time when they get big enough so they're going to cause issues, right? And what's interesting is that coronary arteries, there's a lot of anastomosis where they cross connect. We're talking about collateral circulation. There's like two different arteries that serve the same place. So if this piece of your heart muscle is served by both sides, if you have a blockage here, you're still okay because the other side will take over. But if it's a major artery, or it's the only artery that serves a particular place, let's say it's this place here, and it's blocked, that heart muscle is going to die. So what I'm saying is that if you have collateral circulation, if you have backups, then you're going to be okay. And what's fascinating here is that as you age and as the plaques build slowly, your body gets less blood flow to that area of the heart. It will build collateral branches. So one single well-placed event, plaque, can kill a young person. But if it's kind of been a progressive thing where your arteries have been narrowing, you've built collateral circulation as you get older. And so even if that same place was blocked as an elderly person, you would be okay because other arteries would take over. So I think that's pretty interesting. But these atherosclerotic plaques will form, and as they get bigger and bigger, there's a smaller lumen, less blood flow. So you may start feeling angina when you exercise, and eventually they're small that they can either close off if the artery spasms, or more likely a clot can actually stop and plug it up, and then everything downstream will start screaming and dying. Yeah, and so look at a stable plaque and a vulnerable plaque. They can look in to see, but some of these plaques, if they are in fact, like I mentioned, if they are going to have some changes and they have some bleeding and a thrombus or clot forms right away, that can break off, piece can break off, and maybe it goes downstream a little and gets jammed down here, and then bam, suddenly you have a blockage of an artery, and you're going to have, if that blockage can't be opened up, you're going to have an infarct or a killing of the cardiac muscle in that region. And you may be fine during normal activity, but this will come about when your heart is being stressed, emotionally or physically. Your heart rate is up, and only at that time do the symptoms present. Yeah, as I mentioned, angina. I think I've talked about it. Sure, you can maybe nitroglycerin tablets. Maybe Grandpa has them in a little, carries them with him, put under your tongue. So that is a vasodilator. So it'll dilate your coronary arteries and allow you, to get to the hospital to survive. Mm-hmm. But if you have a blockage, it's going to cause an infarct, an arrhythmia. Your heart's going to start going nuts and beating irregularly. And important to quickly do an intervention. CPR, you can use inversion, these paddles to bring a rhythmic heart back into the proper rhythm. And so treatments for atherosclerosis, when you have these in your coronary arteries, clot busting, oh my God, clot busting drugs. I don't know why that's so difficult. I'm thinking thrombolytic drugs. I was doing thrombus and clot together, but clot busting drugs are given, so important all around at the time of a heart attack. If you can get rid of the clot, if you have chemicals to break it down, you could open it up, right? Well, I'll show you angioplasty. Oh, right here. Yeah, it's when you put a balloon, and it's going to, then you inflate it and it opens up the artery. In this case, they have a stent, which is a kind of a sleeve that goes in that will open. Then they remove the catheter, and the stent remains. So angioplasty gets in there. If you could do that, maybe there's a lot of them, and cardiac bypass surgery. I'll show you a picture of that where they bypass the area. Yep. Yeah, here's a bypass right here. So, and I've seen these on cadavers often. You cut in the heart, and all of a sudden you see these sutures. All these sutures, amazing. And so, here's the issue. Well, instead of fixing the issue, let's just make a bypass. And so they'll take a piece, right? They often take a piece of the saphenous vein from your leg, and they'll put it in there, and it just bypasses the situation. It's a fix. So you can have a triple bypass, quadruple bypass. Yeah. So what happens when you have a plaque that's going to stop blood flow? You have a myocardial infarct. The muscle is going to die. And we can follow this sequence of events. We know that 12, 18 hours, it appears normal, but then the dead muscle is going to start softening. Yeah, so this is the scar. You've killed the muscle cell. So in the beginning, you can look real quickly to be neutrophils if you look in there, but it's going to look similar. Then it's going to start softening and dying. Then it's going to start healing like 5 days later. And over the coming weeks, you'll replace that dead tissue with scar tissue, just collagen. And so that's the deal. Like if you break a bone, you can make new bone. But if you kill a piece of heart tissue, it doesn't really regenerate. And so it turns into scar tissue. And so even if you survived an MI, you have a piece of your heart that is dead. It's just scar. And so the rest of it beats, that just kind of goes along for the ride. And so, yeah, as you continue to have more MIs, your chance of survival gets less and less, the more insults you have like this to your heart. And a cool picture from your book. First of all, you can see hypertrophy of the left ventricle. This muscle, the left side is bigger than it should. Here's the right side. And then you can see these pale areas here and here are recent infarcts. So those muscle cells are dead, and it's going to go through a period. You can see on a heart, sometimes you see kind of a bruising there, but it's going to be a weakened area that will be, your body will replace it with scar tissue, which is useless in heart beating, but at least it's going to protect it. This shows some cardiac muscle after a myocardial infarct, and there's neutrophils everywhere. So they're going to go and they're cleaning up the dead cells and debris. So you have an acute myocardial infarction, acute heart attack, kills people suddenly about a third of the case. CPR, of course, if you administer that, you can keep them alive long enough. And if you do it in the hospital, survival is great because the professionals are doing it. You can have professionals doing it out in the field too, of course, but they've got the drugs. They got a crash cart there. They can give you the drugs right away. They got paddles. So, you obviously greater survival rate if it happens in the hospital. But I wonder, like, how successful, do I give CPR? Turns out, look at this. About 90% of people that have this cardiac arrest are not going to make it. But giving, this is not in the hospital. But giving CPR, the statistics say about half of those you can save. So, yeah, definitely worth it. Like, I know the stats, it's not worth giving CPR. No, it actually works by making the heart move artificially, and especially keeping the breathing. You keep them alive long enough so that some medical interventions can take place. All right. Yeah. So MIs definitely cause arrhythmias, irregular beating of the heart, heart failure. So you can't keep blood pressure, edema. That infarct can grow. You have an area of dead heart tissue, and that's why they want the patients to really rest after that so they can heal. But if they keep stressing the heart, that dead area will actually grow. So you want to stop that for sure. And if you kill off a bunch of your heart, the rest of the heart muscle has to take up the slack. And so you have hypertrophy of the rest of the heart as it's trying to keep up beating without a whole segment of their friends helping. Some less common things can happen, like a myocardial rupture. My goodness, yeah. It usually happens, like I say, about 5 or so days after the heart attack. It's really soft, that tissue, and that pressure can blow a hole in the heart. And then it's going to bleed like crazy into the pericardial sac. I'll tell you what happens then. Or it can be an aneurysm where it can balloon out. Yeah. And they really worry about strokes. They worry about clots, because if you damage the heart, in that region, you're going to have the inflammatory response, and clotting is going to happen. And so the person can have a heart attack and then die of a stroke a couple of days later because they're throwing off clots from their heart, and it's going to travel from the left side up the aorta, up the cardiac arteries, the carotid arteries up to your brain, and it's going to cause strokes. So they give you blood thinners if you've had a heart attack to try to prevent that stroke because of clots that form in the heart. In many cases, you get your first heart attack without having any symptoms before. So it can come on suddenly. You don't have the angina. You can or you cannot. So indeed. And what can happen, and what I want to show you is that if there's excess fluid around the heart or bleeding, a lot of blood in the heart, I have this picture here to show you how tough that pericardial sac is. That fibrous part there is wicked tough. And so that if blood or fluid forms in there, it's actually going to press on the heart so the heart can't fill anymore because there's so much pressure. That sac doesn't give. It just, that's it. And so it's called cardiac tamponade, and it's when fluid forms, and you got to immediately, put a needle in there to release that pressure, to suck out that excess fluid around it, or the heart can't fill. It's just stays there. What's interesting is that you have the normal ECG, but then there's no pulse because the heart can't move. It wants to move, but it can't. So life-threatening, of course. Yeah. And so, how do we diagnose this? You can see here, it shows you some of these enzymes. So troponin, you can see this one, peaks. They know how many hours. This is, all been worked out really well. So you suspected MI, you go in the hospital, they take the blood, they run these, they look for creatinine phosphate, they look for myoglobin, troponin, and from that information, they can say, oh, you had a heart attack. Even without symptoms, you have heart damage if this particular combination of enzymes is in your blood. And ECG. ECG will show you when there's been heart damage, there'll be irregularities in the conduction of the signal. Treatment, yes, here it is, thrombolytic. I can say that, yes. These are clot busting. Remember, lysis is when you lyse cells to burst it. So these are going to get rid of clots, and hopefully if it's in a coronary artery, you can break down that clot, let it move along. Vasodilators like that nitroglycerin going to open up the vessels. You want to give them oxygen so the heart doesn't have to pump harder, right? And morphine for the pain, but also reduce anxiety so your heart is, pumping slower. All right, rheumatic heart disease. This is a bigger problem in places and in children and such. They get strep that are undiagnosed and get strep again and again. And this is a hypersensitivity disorder. We'll see this. It's not necessarily infection of the heart valves directly by a bacteria, but your throat bacteria, you make an immune response against that. You make antibodies, and those antibodies don't seem to be able to tell the difference, and they attack the inner lining of the heart. And the inner lining of the heart, the endocardium, covers the valves as well. And so what we see when you have bouts of strep that's untreated, again, if you have antibiotics, it's going to prevent this, right? But if you don't, you have untreated strep, it could damage your heart valves. And that damage, well, directly it's a problem, but then it can also make it more likely for bacteria to grow on damaged heart valves. Yep, so with rheumatic heart disease, you can have it's damage to the heart valves, definitely. Usually the left side again. Yep. And that secondary infection, we'll talk about that, is that once they're damaged, it makes you more likely to be infiltrated by bacteria. Well, you can get new valves. What's the big deal? Heart valves is a commonly thing that we replace heart valves. And actually there's a choice between artificial valves and pig valves. So you say to yourself, which one do you want? Well, there's pluses and minuses. It depends how old you are, how long you need this for, honestly, how long you're going to live. Because the artificial valves don't last quite as long as the natural valves don't last as long as the artificial valves made out of metal and plastics. With this one, it's kind of annoying because you have to hear this clicking noise. You try to sleep with someone with this click, click, because he actually makes a noise. But the big deal is blood thinners. If you're on an artificial valve, you need to take a blood thinner, Coumadin, warfarin, these things for your whole life, because when blood hits those artificial valves, it can cause clotting, and not in a natural valve. So that's actually a big deal. If you're on blood thinners, you think, oh, it's a big deal, take a pill. Well, it makes you more likely to bleed too, right? So there's some danger there. So they can replace valves, believe it or not, with ones they take out of animals versus ones they make in the lab. All right. Endocarditis is an infection of your endocardium, the inside of your heart lining, and the valves are the big problem. And it can make little vegetations or bacterial growth on the valves, and it just takes this nice, delicate, thin membranous valves and makes them thickened and makes them have like cauliflower growths on them, and they're not going to work as well. It's usually bacteria, strep from mouth or throat, or you can see if you do IV drugs and use needles can push bacteria into your blood. Yeah. And normally get endocarditis, it's a real big risk factor if your valves are already damaged, congenitally, or rheumatic fever, because it allows a place for them really to grow, to get on there. Yeah. And some people that have defective valves already, and they know it, when they go in to do a root canal or something like that, can take antibiotics purposely. Because what happens, is when they work in your mouth, there's bleeding, and some of that mouth bacteria can get into your bloodstream. Where does it go? Down your jugular vein to your heart. And so those strep bacteria can live inside of your heart. This shows some valves, not pretty at all. Look at aortic valve here. You see the growths on it. Yeah, and sometimes these growths of bacteria can dislodge and go somewhere else and grow. So you have this bacteria growing your heart valves is not a good deal. And when they look at IV drug users that have endocarditis, they ask about their needles. Do they share needles? How do they sterilize them? Because you'll get, depends on how that bacteria, again, you're pushing it through the skin, a dirty needle, it's going to push it into the blood, into your veins. And your veins return to your heart, and they carry that bacteria back there. So it's best if we can identify what kind of bacteria so we can hit you with the right antibiotics. Yep. So again, you catch it early, the damage will definitely be less, So infective endocarditis is a real killer. If you have bacteria growing inside your heart and your valves, it's definitely a life-threatening situation. I found this kind of cool. So you can see all the places where you can get bacteria into your blood that can grow in your heart valves. You always have some bacteria in your blood, but usually it's so low amounts that your immune system takes care of it. But imagine a lot of this can get in. Yeah, I see staph and enterococci and strep bacteria. And then looking at, prosthetic is a artificial valve. You can see here, rheumatic fever can damage the valves, right? You got valves that have other diseases. They're not, they make it more likely for bacteria to be able to grow on them. Sutures, like let's say you've had heart surgery, you're probably taking antibiotics so that you don't have endocarditis forming. Yeah. Beautiful. And then I can see the bacteria directly, or that bacteria can adhere to clots as a problem. It says 24% mortality in 6 months. Yeah, so endocarditis is something to worry about. Yeah. And it's usually IV drug users is going to be a right side problem because it's going into the veins and the blood returns to the right side, right? Yeah. All right, so endocarditis is an infection of the inside lining of the heart. Myocarditis is an infection of the heart muscle. And so it's usually a virus, but it can be other things that cause your cardiac muscle to be attacked. And so it's going to cause serious issues, obviously. And when you have a viral infection, of course, we don't have, antibiotics don't help. And so it's good to be able to identify the virus. There's some antiviral drugs, but otherwise, you can see it's a big issue. And I was reading it, it's also the most common cause of heart failure in previously healthy kids, that all of a sudden myocarditis, they have infection of the heart muscle. And so, if it's a virus, again, we don't have a lot of tools, but supportive, just keep you so your heart is not strained and you can make it through this so it can heal. So if you hear about hypertrophy of your heart, enlarged heart, what do you think? Well, one is normal and a really good athlete. They have very big, strong hearts. And racehorses and people that are very in very good shape, definitely. So their heart rate can be, if your heart rate's 30s, 25, I think is you can have a heart rate that low as opposed to a couch potato where heart rate's up in the 70s and 80s. Because remember, cardiac output is heart rate times stroke volume. And if your stroke volume, or how much blood you can pump out, is big, your heart rate can be lower, right? And if you can only pump out a little blood, your heart rate has to be higher to get the same output. So normal is hypertrophy in a well-tuned athlete. But there's lots of pathological causes, right? If you've got hypertension, high blood pressure, your heart's going to get big. It's stenosis of the valve. It's got to work harder. So all these causes of hypertrophy, most of them are not good. So yeah, you've got high blood pressure, hypertensive heart disease. Look how thick the wall is there because it's that workload. The cells are going to hypertrophy. They're going to get bigger, just like your biceps get bigger when you work it out. And when it gets bigger, when it grows that bigger, you're at risk for not being able to give it enough oxygen, right? So it gets so big, the blood vessels are not enough of them. It's going to be starving for oxygen. Now, if you have an issue with the lungs, the right side of your heart is going to have to work much harder to push the blood through your lungs. So Cor Pulmonale, Coronary, Pulmonary. So that's what it means. So you have a lung issue, your right side is going to be dilated and thicker because it's working harder to push it through those lungs. Yeah. And your right side will get bigger too if the left side's not working either. It's all connected because it goes through the lungs to the left side. And if your left side's not getting rid of it, it's going to back up and cause more pressure. So they are related, of course. All right, we read cardiomyopathy. It's heart muscle disease, right? And so you can have where the heart muscle is dilated, where it's super thick, hypertrophic. Restrictive means it's not very flexible, so it can't stretch anymore. And yeah, these can be caused by, maybe you have some genetic defect where the proteins in the muscle are going to not allow it to stretch much or work properly. Look at that. Fibrosis because of radiation, or amyloidosis is a normal protein in there. Yeah, alcohol toxicity. I know alcoholics will often have hypertrophy of the heart. All right, real quick with arrhythmias. Arrhythmia is your rhythm, and arrhythmia means, without rhythm. And so y'all should know bradycardia and tachycardia. I think Tom Brady is getting a little slow in the Patriots. So bradycardia is a slow heart rate, and tachy is a fast heart rate. And these numbers, you get on the treadmill, you're going to be tachycardic, right? So these things are just for, on average, normal resting people. And so some of you out there have a lower heart rate than this, and you shouldn't go to that worry because you're bradycardic. You just happen to be. What's this? I see a nice QRS, right? Those peaks, solid. But what about the P? Yeah. So AFib, or atrial fibrillation, is when your atria, instead of having a nice rhythm, they're fibrillating. They're going chaotically. And many people have AFib asymptomatically. You don't even know it. You're walking around with AFib. Normally what occurs is that instead of the SA node being in charge and giving a nice signal, is that you have numerous places that are acting as pacemakers. So all of a sudden, SA node is supposed to be your pacemaker. Then this joker over here decides, I want to be a pacemaker. And so it sends out signals at a different rate than the other pacemaker. And so you have this chaoticness to it. And so they can go in and do surgery, the electricians, and they can go in and like burn off when they can determine where that ectopic pacemaker is, and they can go and kill it. Right? And then it goes back to the one person being in charge. But AFib, we'll talk more about it, but yeah. But you know what? You can live with AFib. Like I said, you can be asymptomatic because your ventricles are doing the big work, aren't they? Remember, your ventricles actually fill. 70% of the blood just fills just by gravity and just by suction. And then the remaining 30% is squeezed in by the atria. But as long as your ventricles are working, you'll be able to survive. This you don't survive. This is VFib, or ventricular fibrillation. If your ventricles are just running chaotically, you're not getting blood to your body. If you got a heart rate of 300 to 600, yeah. I mean, if a hummingbird does, this is normal for a hummingbird. It's not normal for us. So this AFib is quite common out there. I don't have the percentage here, but well, as you get older, it's more likely you get AFib. I mean, I see commercials on TV for the medications for AFib, right? And so some of the problems, of course, is that it could lead to VFib. It could lead to problems because the atria contract, remember, then the ventricles can contract. And so there's that handoff of the signal. So that's a problem. You got to make sure that's okay. And then because you have turbulence in the blood and some stagnation in the blood, clots. So it's a big problem with AFib. They treat you for clot busting chemicals, medications, definitely. Yeah. So yeah, in men, you can see 8% of men over 80. And so AFib comes about. And so you look at this nice, see that chaoticness to where it should be a nice smooth P wave, right? Yeah. And you'll come in and they'll do an ECG like, did you know you had AFib? And then, yeah, well, we should worry about clots, and we should worry about getting you in a better rhythm. Yeah. So yeah, treatment, they can shock you. I mean, they look at your age and whether how healthy you are, what they want to do here with what drugs to use or other interventions. But you want to get it back to coordinated, a nice coordinated contraction up there. So they want to figure out what's causing it. Maybe they could do some surgical intervention. And they always worry about clotting. Like I say, with AFib, is that you've got blood up there that's being jostled around. It's going to show some clots. All right, neoplasms, cancers. Rarely do you have it being in the heart. Of course, you can Google and find some images and see these tumors in your heart. So yeah, it does occur, but you don't hear a lot about it. Often it's metastatic. It doesn't form in the heart, but it travels there because the heart's going to be carrying all that, and it may stop and grow there. But pretty rare to have neoplasms of the heart. So failure of your heart, right? I mean, death is going to be the major issue. It's a major issue, right? We talked about shock. And so cardiogenic shock, right? Genesis. So heart cause of shock, right? And so if you don't have enough blood perfusion, you're going to go into shock. Remember, your kidneys, your brain, and yeah, your body, like, it goes through a sympathetic response. I mean, if it's got low blood pressure, it constricts those vessels. And so your poor kidney has got this constricted vessel. Maybe the pressure isn't up, but there's not much blood perfusion. And so it starts failing. And then if your heart can't get rid of the blood, you've got edema, right? Because the pressure is going to back up and you're going to have this loss of fluid. And congestive heart failure, inadequacy of the pump, it cannot get rid of the blood enough, right? So whenever you have congestive heart failure, you're going to have edema. Ankles are going to swell, fluid in the chest, fluid in the abdomen. And they need to see what's the cause of the congestive heart failure. So in and of itself, you got to look at what is causing this and see if they can go back to the cure, because they can give you diuretics, so you pee more. They can give you less fluid. Digitalis is a drug that makes your heart beat a little stronger. They can do these things, but you're just treating the symptoms. You got to see what's causing the heart failure. And they talk about right and left heart failure. And so the right heart failure is the right heart is pumping it to the lungs. And so if that is not pumping it out to the lungs, it also receives the blood from your body. So it's going to cause that edema. And before that inferior vena cava is your liver. So your liver is going to swell, your spleen is going to swell, you're going to have fluid in your abdomen. You're going to have neck, veins are going to swell because you can't get rid of it. And then it's trying to push it through the lungs. And so you'll have hypertrophy of the right side. The left heart failure is going to be, when that happens, you're going to find also a backup in the lungs, because the blood goes from the lungs to the left side. And if you can't get rid of the blood, it's going to back up back there, right? Yeah, so you're going to have dyspnea, as shortness of breath. Yep. And so you can see, looking at left and right heart failure, you can see the difference. The right side here, look at all those veins swelling, because that's where the blood returns to that right side and you can't get rid of it. Yeah. And so congestive heart failure, you can have people that have that die quickly, or people that live a long time with medications. And so they've had grades of this have been proposed. And you can have it, and you have these symptoms, and you can control them with various drugs to allow you to live quite a long time in some cases. So there's gradations of congestive heart failure. But once the heart is damaged enough, you need a new heart. They're working at artificial hearts. Sure, yeah, we don't have those quite yet to completely replace the human heart, but very expensive. I think it's like $1 million up there, many hours to do this. But they simply cut out the heart. They leave the back wall of the heart. They cut out the front of it. They take a new heart, a donor heart, cut out the back. They sew it back in, right? And they got to cool you down, right? And everything's open. So it's a major thing. Yeah, but they've been doing it for a while. Big waiting list, of course, for real hearts. The kidney's about $250,000, much cheaper to replace a kidney than a heart. Yeah, so you click on that link. You can see, because now we got to transport the hearts quickly, right? You see them on the airplane in the cooler real quickly. They got this machine that helps it last longer. And in the future, why can't we have frozen hearts? Or even better, the best is if we could, let's say you're having heart issues, or even not having heart issues. They could take stem cells and grow a new heart and just replace it, like you replace your oil. Imagine that. Every 20 years, I replace my heart just in case. I mean, that could be the future. I think it will be the future, honestly. I don't know how long it'll take. So artificial hearts, again, they're working on it. Engineers are working on making one that we can just put in a machine. I think that's pretty cool. They do have these, these are almost an artificial heart, these left ventricle assist devices, where, remember, that's where you need it really, is the left ventricle. So you can see it sucks the blood out here, and this provides the power and shoots it out the aorta. So your heart is not powerful enough to pump the blood out, and so you can use this machine, and it keep you alive a long time. Talk about a bridge to when you can find a transplant. Yeah, so you can imagine this is just helping your heart. All right, last slide finally. Again, the future really is instead of making an artificial heart, all these things. I mean, that's cool, robots, everything. But if we could use your own cells to develop your own new heart, I mean, how beautiful would that be, right? You use a heart for 50 years, you make a new one, right? And you can make a clone of yourself and then harvest the organs, but a lot of issues there. But here's an idea. They're already using stem cells. And remember, a part of the heart dies, it's dead. It turns into scar tissue. But we want to be able to put some stem cells and chemicals and maybe like a scaffolding for it to grow on, and have you grow new muscle cells. And they can actually contribute to your heart instead of just being scar tissue. So yeah, that's definitely the future. All right. There we go. So talked a lot here about issues to the heart itself, right? And atherosclerosis, hypertension are all going to contribute to heart failure. All right, so we talked about infections, possible neoplasms, issues of the right and left side. So a lot to talk about with the heart, because again, it's the #1 killer in the US is heart issues. All right, you guys, hope you enjoyed.